Respected teachers, my dear friends, good morning everyone. At the outset, I want to thank Vijayana, Yashoda Hospitals and TASG for giving me this opportunity. So, this is more of theoretical topic because we are covering all surgical aspects in master videos. So, after total gastrectomy, what are all the options for the reconstruction? Before that, why we have to reconstruct? To maintain that, to restore that alimentary tract continuity and to ensure adequate nutritional intake and to minimize the complications of reconstruction like reflux, stasis and malabsorption. Actually, what happens after gastrectomy? If you see, you are going to lose your reservoir where you will get lower calorie intake and weight loss, and you are losing the pylorus, which will lead to dumping syndrome. You are losing the lower esophageal sphincter, which will lead to the reflux, and you are losing the parietal and chief cells, which will lead to decreased absorption and breakdown of the proteins and vitamin B12. Not only that, even loss of acid will lead to the bacterial colonization. So, what will be the ideal reconstruction procedure? So, you should have a gradually emptying, non-refluxing, large volume with the duodenal continuity. That is the ideal reconstruction method. So, that is why post total gastrectomy, the reconstruction methods are divided into two. One is having duodenal continuity, one is without duodenal continuity. And in that, whether you are doing pouch or without pouch. So, post total gastrectomy without duodenal continuity, the most commonly performed is Roux-en-Y esophagojejunostomy or loop esophagojejunostomy with Braun, and with or without pouch. If you see, duodenal passage is, if you are preserving the duodenal passage, you have to have a jejunal interposition with or without pouch. So, this is the most commonly performed. As you all know, 45 to 60 centimeters of rolling will be there. It will be end to side anastomosis with leaving the small end pouch, and with the side to side or end to side jejunal anastomosis after doing stump closure. So, what are the benefits of it? It will cause reduced bile reflux, and obviously apart from your duodenal stump closure, you will have only 2 anastomosis, but it carries all stasis syndrome. You will lose the endoscopic access, and definitely post gastrectomy you may have nutritional deficiencies. What to be done? Whether to do hand sewn or a stapler? As you all know, with the stapler, there will be with the stapler and hand sewn, there won't be any difference in anastomotic leak and anastomotic stricture, but there will be lesser operative time with the stapler, definitely with the higher cost. Whether to choose circular or linear stapler? So, with the circular stapler, it is proven that stricture and bleeding rates are high, but if you see the leakage, both are similar, and definitely linear stapler will be lesser costlier than circular stapler. And about the interpositions, you will take free jejunum around 15 to 20 centimeter with intact vasculature. We will use isoperistatic limb, end to side or end to end esophagojejunostomy anastomosis, and with the side to end or end to end esophagoduodenal anastomosis will be there. With this, if you see, this is more physiological with duodenal passage preservation, you will have a good nutritional improvement and absorption, and definitely the weight recovery will be good, and if you have polyps and all, you have access to the duodenum, but it will carry bile reflux and definitely increased number of anastomosis will be there, and if the patient is obese and the short mesentery is there, technically it may not be feasible. If you see the literature, there is no significant difference between the Roux-en-Y esophagojejunostomy and jejunal interposition. About the pouches, so I think most commonly done is Hunt-Lawrence pouch. So, they will take 12 to 18 centimeters of pouch of jejunum with the end to side pouch anastomosis, then followed by jejunal. And if you are doing jejunal interposition with the pouch, the same jejunum you will take bigger length and you will make a pouch in the proximal end. You will do the anastomosis to the pouch, then followed by jejuno-duodenal anastomosis. What are the advantages? It will have a reservoir function definitely with the neogastrium. It delays the emptying with the lower dumping syndrome and improved nutrition. But it carries all pouch problems like stasis, pouchitis, and definitely more number of anastomosis will be there. It will take longer time to operate. So, what is the ideal length of pouch? The 12 to 18 centimeters is ideal. If you take less than 12, it is called short. If you take more than 18 centimeters, it is called long pouch. So, longer the pouch, better quality of life and outcome, but increases reflux and stasis complications and bloating. So, per pouch versus no pouch, 14 studies are included in meta-analysis, including 1570 patients, and which showed with the pouch there will be better body weight gaining and improved quality of life and improved nutritionally with the total protein and albumin with lower dumping syndrome. But there is no difference in leak rates in pouch versus no pouch. So, my previous speaker was talking about double-tract reconstruction. This is with the double-tract reconstruction, the advantage is definitely you will have a duodenal access to do endoscopy and with the better absorption, and it will reduce the dumping syndrome. But definitely anastomosis will be the length of suturing will be more and longer operative time, and it is proven that there is no established better outcome. In this study, only 4 patients they could recruit, but which showed better for duodenal surveillance if you have familial syndrome to access the polyps. Very limited sample size, that is only 4 cases are included. The last note about colonic interposition, you can use the ileocecal distal ileum with the cecum. There the ileocecal valve reduces the dumping and cecum acts like a low pressure reservoir, and you can have a duodenal continuity and you can access with the endoscopy. But the disadvantages are longer operative time, anastomotic leak rates are high, and the motility disorders can come and chronic stasis can cause problem. These are all the options to reconstruct after total gastrectomy, but as you all know, most commonly done is esophagojejunostomy anastomosis. At times and few groups are following even pouch, but with the without duodenal continuity. Thank you one and all.